So, sequencing of therapies in the setting of relapse CLL is very important. However, I think we do still have a lot to learn, and hopefully, prospective studies will help guide us. I think in the current landscape in 2025, we know, at least from both real world and some prospective data, that there are multiple sequences that work quite well for most patients. And I think it's actually pretty uncommon to have patients get to a situation where they're failed by all of our modern therapies. So in general, if you start with a covalent BTK inhibitor, I would do venetoclax and or pirtobrutinib, depending on whether a patient reaches the third line or as a preference for oral only therapy, which would then lead me to prefer Perto over venetoclax, which I typically combine with the CD20, although it can be used as monotherapy also. However, it's important to consider the reason for the covalent BTKI discontinuation. If a patient had intolerance, then another effective approach following the covalent is to just try a different covalent, which may have better tolerability. And we've seen that in multiple studies where probably about 70% of the time patients are going to have a better experience on a different covalent BTKI with better tolerance and lack of recurrence of whatever side effect the patient had. Another thing to think about is that venetoclax retreatment is an option, and we're seeing emerging data both from relapse studies, but also patients who received ven in the front line who got ven in the second line in the prospective ReVen-G trial. So that's for patients who started with a covalent BTK inhibitor, but also a little bit of information on patients who started with venetoclax. There remain to be a lot of effective options, and we still have a lot more to learn. Perhaps if there's one true superior sequence, that remains unclear. It seems like there's a lot of effective sequences right now.